Hello, everybody. Okay. I guess we'll get going. Let me start by congratulating Dr. Kalis, our newest non-invasive imaging fellow. Congratulations, Maya. We're very excited about this new role you're going to have soon.
Thank you, Dr. Paz.
You're very welcome. We're very excited, very happy, very proud. Lots of berries. So also, I hope most of you will be attending the pink elephant or the white elephant competition today. Should be fun. Alina's got some fun in store. Also, there'll be lunch. All righty. So this is a 6-week-old who has intermittent tachycardia. Question is this jet? Why not? And what, if anything, is the treatment? So why don't we ask Dr. Bezdakova what she thinks?
Good morning, Dr. Paz.
Oh,
Looking at this rhythm strip, it looks like the rhythm is pretty regular between the R to R interval. I would say about 2 boxes, so a rate of 150. For a 6-week-old, this rate could be regular though, at 150.
okay.
And then just going from left to right, looking at the rhythm strip. Initially, I don't see any P waves. And then I see P waves at the 5th beat. And then yeah, as your pointer is, and then going on to the next one, I see it looks like the QRS is morphology changes in comparison to the beat before it. And then there I do see P waves. And then as you go onto the rhythm strip, the P waves start to go away, and then the QRS complex goes away. So I wouldn't say that it's jet, but with the QRS morphology changing, maybe it would be could you say that it's an accelerated ventricular rhythm?
Yeah. So very good. So the point of this slide is to show that QRS morphology has this sort of, I'd say, 2 points of this slide. First is the QRS morphology has changed, right? I think we would all agree that at least these 3 beats in the middle look different than the beats to the left or the right of it. Okay. And so when someone has jet, of course, the other name for jet in Europe is His bundle tachycardia. And when people have His bundle tachycardia or jet, the morphology of the QRS should be the same as that in sinus. And so the fact that the QRS morphology has changed in the arrhythmia versus the sinus beats is a very good indication that it is not jet, and it may be acting clinically like jet, and sometimes in postoperative patients, there's no real clinical difference between the two. But in terms of where the arrhythmia is coming from, we would formally call this either VT or accelerated ventricular rhythm and not jet. The other interesting point that I think is important is, if you look at the rhythm strip on the bottom here, the QRS looks quite a bit more regular and similar, even in the conducted beats in the middle, than it does on the surface electrocardiogram lead that's above it. These are obviously simultaneous two leads. I think this is, I don't know what this is from. I guess it's from a monitor. The point I'm trying to make is it can be very important to always get a 12 lead when you're trying to assess any abnormal rhythm, particularly in the ICU. If somebody is stable in an arrhythmia or not acutely dying from their arrhythmia, you always want to try to get yourself a 12 lead electrocardiogram. If you had only had this rhythm strip, the bottom part, you could make a strong argument that this is some form of jet, because these QRSs, although there is a subtle difference between these beats and these, they're close enough in morphology that you might be fooled into thinking that the morphology is the same in the arrhythmia and out of the arrhythmia transiently. But in fact, as we see clearly in this rhythm strip, in this lead, which is obviously looking at it in a completely different orientation on the surface electrocardiogram, the QRS morphology is totally different. And so that's an important point, because oftentimes we just look at the monitor and it doesn't give us all the information that we would like. Unfortunately, most of the time, the monitor we only get one lead of the electrocardiogram, but always if there's more than one, you should try to get that other lead on the tracing as well, because it can be very useful. Now sometimes if someone has a transient arrhythmia and it goes away, then getting the 12 lead is not going to be particularly helpful, obviously. But if someone is kind of doing this in and out, then not much to do about it. Now, let's say you are seeing this in an infant who, let's say, had tetralogy of Fallot repair 4 days earlier, is now extubated and is in the ICU, recuperating from surgery. So why don't we ask our friend Dr. Capon, what would you do for this, Ivana? Patient is in bed, is feeding, has a fever, and this is the rhythm that we're seeing.
Good morning, Dr. Pass. So firstly, I would assess the clinical stability of the patient. Obviously, we would go down a different algorithm if he or she was hemodynamically unstable. But if the baby was stable, first things first, would try
I'm
to.
sorry, I don't mean to interrupt, but I think Harvey had something he wanted to say about this. Did he
I
say?
think Harvey agrees. He
Okay.
thinks first would optimize kind of the environmental factors, so control the temperature of the baby, perhaps optimize Precedex if that's what they're on.
Okay, they're on no Precedex. They're actually extubated. It was a national Precedex shortage that week, so we don't have any Precedex available.
Got it. So control their fever first and foremost.
Okay.
And then depending if this is sustained or not, are we calling this jet? I'm sorry. Are we calling, I know this is accelerated ventricular rhythm, but for discussion purposes, are we?
No, we're calling it exactly what it is. So this is some accelerated ventricular rhythm.
I mean, if it wasn't bothering the patient, I'd probably just observe it for a while and see if it would kind of self-terminate on its own.
Right.
So I wouldn't do anything just yet.
I think that's fair. I mean, I do think that when you see an arrhythmia like this, though, if this was the first time in the post-op course, right, I think we would agree it's a little unusual to have this happen on post-op day 4. Not unheard of, but unusual. So
Mhm.
one would want to sort of, I think if it just resolved with fever, then we could just sort of follow it. I would be very cautious about giving, I'm glad you did not say give IV amio. We really don't want to give IV amio unless somebody has got something that's kind of has a chance of killing them. This does not likely have that possibility. It's not impossible to imagine, but it would have to be much faster and more angry looking than this. And in someone who's hemodynamically stable, it's unlikely that's a problem. And obviously, the reason I'm saying that is because of all of the various morbidities associated with IV amio in infants. Okay. And not to mention, by the way, the morbidity of chemical burns. I cannot tell you how many times I've had patients who've had IV amio given peripherally who've developed some kind of a chemical burn. And I can tell you, even if you were treating the most dangerous of arrhythmias, families, all they remember is that burn, is that small little patch that needs a skin graft or something like that. It's very interesting and quite reproducible that people really don't like that. So I would caution you about IVM, as much as you can to give it centrally if needed, but in this case, for sure, not necessary at this stage. Okay. Any questions about that? All right, let's move forward. All righty. So this is a tracing of an ICD patient. And this was on the memory of their device. This is a post-op congenital patient who is an adult congenital patient. And so the question here is, what's going on? How would you evaluate this? Why don't we ask Dr. Obsikov what he thinks is going on here?
Good morning.
Hey, how are you, Glenn?
So I'm not quite sure what this box on the left is, but my interpretation of it is that the two rhythm strips on the right is just like a zoom in from that blue
So
spot on the left. Is that
let me
correct?
orient you, because part of the reason I'm showing this is I just want you to all see what this involves. So just to reorient, everybody who has an ICD, ICDs have a memory in it. Pacemakers do also. It depends how you program it. But the device will record anything you ask it to record. In this case, you can have what's called a VT and a VF zone. And a VT zone can be a zone where you just, you say, well, if the heart rate exceeds 170, I want you to record it. And, you can say, well, if it's over 170 for, 40 seconds, then I want you to deliver a shock. Or you can say, I don't want you ever to deliver a shock above 170 unless it's above 100, above 200. And that's how we mostly program our patients. In adults, particularly older adults, where the likelihood of someone being in sinus tachycardia above 170 is almost zero, you can make these zones where you allow the patient a little longer period to stop on their own, and then if not, to deliver a shock. So on the left-hand side, you can see that it's giving us a graph of the A to A and the R to R intervals, or the V to V intervals, and it's measuring the A to A those are depicted on this drawing or this graph as little squares, and the V to V are little dark circles. And so basically what's happening here is, and it's measuring it in cycle length, okay, because that's how the system looks at the P to P or the R to R intervals. And so what you see here is that during what is referred to as detection, something is happening, there's a clustering of the A's and the V's in this general vicinity, and then we have this. So, and then on the right-hand side, they're giving us the electrogram. So it says A-tip to ring. So this is basically what is being recorded off of the atrial lead. And then R-tip to RV coil. This is what is being recorded on the ventricular electrogram. So this is essentially the atrial electrogram. This is the ventricular electrogram. So now that I've given you that orientation, what do you think's going on?
I see. Thank you. So it looks like you on the left hand side of clustering of your little dots in the graph to a shorter interval, so a faster heart rate. And it looks like your boxes for the A's are actually clustering lower than your V's, so your atrial rate is faster than your ventricular rate. And then on the right hand side, looking at the rhythm strips, the ventricular rate on the bottom looks quite irregular and maybe at a rate of like 170-ish, a little higher, faster even. And then your atrial rate above it is even faster. It looks like maybe it's over 300. So this makes me think this is something like an AFib where you have like an AFib or like an irregular rate from an atrial tachycardia.
That's right. And that's exactly right. And so the other reason it's AFib is because not only is it very fast, as you just described correctly, but it's irregular, right? The P to P interval is all over the place. Even the electrograms itself, right, are very different. Each one looks a little different than the other one, which is consistent with what we think about atrial fibrillation, which is that the atrial rate is very fast and that the foci are coming from multiple locations. So this is an example of somebody who's having intermittent atrial fibrillation. Okay, and according to the device, the episode lasted 8 minutes and 25 seconds. So, what do you think you would do about this? So you're Dr. Zadie, we'll say, or Dr. Hopkins, and this is your adult congenital patient, and you've got this download. How would you evaluate or manage this, do you think?
Well, my first question is whether or not this ICD device delivered shock for this.
It did not, because the device was programmed. I'm not showing you the actual program on this patient, but the device was programmed to only shock him for ventricular rates above 220.
And so in that case, I would call the patient. Well, first I would see if it's a one-time episode or if it's happening recurrently and for how long they're lasting.
Okay, so again, remember that this is telling us that this particular episode lasted 8 minutes and 25 seconds. And I might add, there are no other recorded episodes in the last 3 or 4 months that the device has been, downloaded since it was downloaded.
So then I would call the patient, see if they notice this episode, see if it happened while they were awake, asleep, or doing some sort of activity.
Turns out the patient did not feel this. How common is that, by the way?
I don't have a number, but I think it's extremely common.
Yeah, I mean, it's a little strange with the heart rate being 170. You would have thought he might feel that. But this particular patient did not feel this episode. And it is common that people can have AFib intermittently and not feel it. In fact, it's one of the more common causes of occult stroke. Cryptogenic stroke is that people are unknown to them having intermittent episodes of AFib. And this is one of the reasons why it's considered to be fairly standard that if you have someone with a cryptogenic stroke and they don't have any other obvious explanation for why they're having the stroke, that typically it's recommended that someone be monitored with like an ambulatory ECG or something like a link device for, a month or 2 or 3, because it used to be that we would just like admit them to the hospital. They'd get 24 hours of monitoring. If they were in sinus rhythm, we would say, oh, they don't have AFib. But actually, there's quite a bit of evidence that the longer you monitor patients who have these strokes, that the more you become, the more obvious it becomes that they are in fact having little episodes. Okay, so you know that this patient only had 1 episode of AFib lasting for 8 minutes and 25 seconds. So anything else you might do or this stage?
You said it's the patient with congenital heart disease?
Patient does have congenital heart disease, has a defibrillator because had a history of VT in the distant past. Actually did have a history of atrial arrhythmias and is on high-dose sotalol.
I think in this case, we already have an echo, so we know what their underlying anatomy is, and if they have a risk for a right to left shunt or stroke. I think I would probably want to repeat an echo at some point. I don't know if you would do it now after this one episode or wait to see if they recurrence to see if they develop any thrombus.
The reason you do an echo is why, Vlad?
To look for a thrombus if
Look
this
for
is
a thrombus.
persistent AFib.
Well, okay. We know it's not persistent, right? Because again, the device is telling us that the vast majority of the time the patient is in sinus rhythm. Also, I would remind that although I don't disagree with doing an echo is not a good way to rule out a thrombus. It's only a good way to rule in a thrombus, right? If you see something, then yeah, sure, it's helpful, which is why I would never disagree with the decision to do an echo, but I would, caution you that, the only real way that we think confidently we can rule out a thrombus is to do a transesophageal echo, or that they say in the UK, a TOE. So you would want to call your friend Dr. Kalis to do a TOE to confirm that if the patient were stuck in this. So in this particular case, given that they already were on sotalol, given that they only had one episode known, the decision was made to continue to expectantly monitor this patient. But, I think this highlights an issue that is going to become more prominent, in which all of you are going to see much more in your careers than I have, because as you get older, there will be many, many more ACHD patients than there are even now. And that is that I think AFib is going to become a very, very prominent problem amongst the adult congenital heart patients. I think the only reason we haven't seen this as prevalent as it is going to become is simply because they didn't live as long in the past. But now that we have much better treatment for them, now that there's transition programs, that there's ACHD doctors who know what they're doing, like Dr. Hopkins and Dr. Zaidi, and others, I think that this is going to become a very common problem amongst the ACHD patient, and I would hazard to say that it's going to be far more common than the general population amongst these patients. And so these people are going to need, I wouldn't be surprised if this particular patient one day needs an atrial fibrillation ablation. And these can be very challenging because of the complexity of doing an AFib ablation, even in someone with a structurally normal heart, but then add to it the scars from prior atriotomies. And one could imagine that it would be a very challenging procedure. Now, there is newer technology, pulsed field ablation, which is a new form of energy, which is really revolutionizing that field. And now Carto has integrated it into their platform. And so I think they're able to do AFib ablations in standard patients much faster and more efficiently and more successfully than they have in the past. And this is only going to get better, which is great for our ACHD patients. But I think this is going to be a very serious problem in the future for for many of our ACHD patients. And this is also, by the way, one of the reasons that I've never been a huge fan of closing gigantic ASDs with gigantic devices, because of concerns that we'll have to go back into the left atrium one day and do this. Now, it turns out that there's a fair bit of evidence to suggest, at least anecdotally, that crossing the Gore device is feasible and not terribly difficult. There's even been evidence that you can go through an implanter device, but I'm sure that it is not easy and enhances the risk of the procedure for any other reason than just that it probably inhibits the motion of the ablation catheter because you're stuck inside of a device. I could certainly imagine that might make an ablation much more difficult in the left atrium following ASD closure. Also, I've had the experience of being unable to ablate AV nodal reentry in someone who had an ASD device closure. I once cared for a young lady who had an ASD closed when she was 3 or 4 years old. And when she was about 16, she started having SVT. She had AVNRT, and the device had so much scarification on it that I could not deliver a radiofrequency current at the area, at the slow pathway area in the lowest third of Koch's triangle. There was just so much scar there. It had no impact at all. I even sent the patient to a very prominent adult electrophysiologist in Boston, and they spent like 16 hours trying unsuccessfully to ablate it. So that's another concern with devices. Thankfully, very rare. Only time I've personally seen that. But anyway, I thought this was interesting strip just to show you all of the great information we can get on remote monitoring in a patient like this. Any questions?
Dr. Pass, sorry, Dr. Pass, I have a question about this. Since this patient's already on beta blocker, given how long this episode was, I know this patient didn't feel it, but if they did feel it, would you consider this to be a candidate for the pill in the pocket?
Well, I would remind you that the patient is on, as I mentioned, is on sotalol, which is actually not just a beta blocker, right? Sotalol is a class 3 agent. So I think we would be a little well, first of all, pill in a pocket is really only useful for people who know they're in the arrhythmia, right? Pill in the pocket is a technique where, as Vlad's suggesting, you give a patient, let's say, 300 milligrams of flecainide, And you say, look, in the event that you're having AFib, you know, take your pulse. If it's like irregular, if it's over 120, you know, sit down in a comfortable location, take your medication, and, you know, something like 60 or 70% of patients will convert in about a half hour to an hour. So that's a possibility for most patients. But this case, I would say, is not a great candidate for pill in the pocket for two reasons. First of all, they're already on sotalol. So adding a class 1 to a class 3 agent, although I think it could be done safely in a monitored setting, I would certainly not feel comfortable having a patient take a large dose of flecainide on top of what is already, I haven't mentioned the dose, but the patient's on a very high dose of sotalol as well. I think that that could be potentially very proarrhythmic and dangerous. But if the patient was on no antiarrhythmic therapy, and if the patient could feel this arrhythmia, then I think it's certainly not unreasonable to consider a pill in the pocket in a patient like that. Most people who do pill in a pocket, for the first episode, they will recommend that they come in and be monitored while they're taking the medication, just to be sure that, you know, nothing bad happens. I'll tell you a funny story. My friend Sylvia Griffith, who recently died, who was 99 and was a pediatric cardiologist, trained by one of Dr. Tausig's fellows, Dr. Whittemore. Dr. Griffiths had atrial fibrillation, and they gave her flecainide for pill in a pocket because she would have like 1 or 2 episodes a year, and it made her, she could tell immediately when she was in it. She also was very compulsive about checking her heart rate twice a day, always. And they gave her pill in a pocket, and she said to me that she said, Robert, don't you think it's dangerous for me to take this at home the first time? What if I have an arrhythmia from the medication? And I said, actually, Sylvia, I don't disagree with you. And so she actually, the first time she did it, she actually went to the emergency department where they monitored her as she took the medication. In the end, she ended up being put on propafenone, which is also a class 1 agent in the similar classification as flecainide. And actually on propafenone, to my knowledge, she never had AFib again. It worked very well for her. Propafenone is generally preferred in older patients as chronic therapy because of the association of flecainide with coronary artery disease and worse outcomes. And although I don't know if Dr. Griffiths had coronary artery disease, I assume that when you're in your 90s, you just sort of make the assumption that the patient may have some coronary disease. Anyway, it worked very well for her. So pill in a pocket, great idea. Probably not a great idea in this patient because A, the patient doesn't know they're in it, so they wouldn't know when to take the pill in a pocket medication. And B, this particular patient is already on a class 3 agent, so that combination could potentially be dangerous. So, all right, I think you guys did great today. Very good answers, a couple of interesting conversations about things. I think we'll stop here. Hope everybody has a wonderful day. Look forward to seeing everybody at noontime. Have a good day, guys.
Thank you.
Thank you.
Thank you.
Bye.
Thanks.